I think we can start this session now. It's 9:02. So I'll begin by welcoming everybody. Good morning, good afternoon, good evening from wherever you are. So on behalf of WHO's hepatitis program, I warmly welcome you to the fourth session of our global webinar on viral hepatitis that is supported by Project ECHO. I recognize many regular participants and new participants, and I welcome you all. Now, the platform was established to facilitate exchange of knowledge and to share implementation experiences from program managers and policymakers all over the world in WHO member states. And the goal is really to learn from each other and to participate together in shaping the response for viral hepatitis for impact at the country level. Today's topic is on new directions in hepatitis B care and treatment, and with a focus on country feedback to inform the new WHO hepatitis B guidelines. Of course, we know that over 300 million people live with chronic hepatitis B, most of whom do not have access to care and testing. And from the 2021 report, only about 10% of this 300 million have been diagnosed. We know that nearly 800,000 people die every year from the chronic complications of untreated hepatitis B infections, especially through liver cancer and liver cirrhosis. And the global strategy identifies the importance of increasing access to diagnosis and treatment as one of the key shifts to ending the epidemic. So it's critical to hear from you as we revise and reshape these hepatitis B guidelines. On the next slide is the agenda. And today promises to be a very, very exciting session. We have with us expert members from WHO headquarters in the form of Dr. Philippa Easterbrook, who will provide an overview of the topics for the forthcoming guidelines meeting. We also have experts from the various regional offices of WHO and country offices. And we have Dr. Sandy and Dr. Billy, who would highlight some of the perspectives that we have received through the survey from the National Hepatitis Program Managers on 6 key topics for the update. We have a 40 minutes discussion with participants on key themes, and these will be anchored by colleagues Dr. Kazmir and Dr. Bibi Rewari. And at the end of the session, at 10:15, we would have a brief closing remarks. But before we start, I'll quickly like to highlight some of the important housekeeping issues for us to be aware of. And on the next slide, the interpretation is available in English and French, so please go ahead and click on interpretation and choose the language you would like to hear. You are able to mute the original audio to hear the interpreted language only. Live transcription is available, so click on the caption in the chat and use the chat for questions regarding topics. And this will be a very interactive session. We encourage you to use the chat first to share your names. Already we have 64 participants on the call, and there will be lots of polls that will require responses during the Q&A sessions for each of the key priority areas of the discussion. On the next slide, we'd like you to also rename your Zoom ID, just so that we can recognize you, recognize where you're coming from with your first name, last name, and importantly, please include the country where you live and work. The session is being recorded, and your consent is believed. The recordings and the resources, including the PowerPoint, will be shared after the webinar, and a certificate of attendance will be available through our partners, Project ECHO. And on that note, and without further ado, I would like to call on the next slide and invite my colleague, Dr. Philippa Easterbrook, to give us a brief overview of these new directions for hepatitis B guidelines. So we thank you, Dr. Easterbrook. We welcome you again to this session, and you have the floor.
Good morning, greetings everybody, and this is a great opportunity to be engaging with the key MOH country focal points and leads in viral hepatitis, and to hear your perspectives on some of the new planned directions for the WHO Hep B guidelines. I'm going to run through these slides relatively quickly. These are scene-setting slides for then the subsequent presentation, which is a feedback from the survey that we've recently undertaken, and are grateful to many of you who took part in this, and to feedback the results that will then lead into the discussion that follows, and really to encourage you to actively participate in the discussion, both in the chat and verbally. Next slide. So I think it's already been mentioned, we have recognized the major gaps in testing and treatment uptake for hepatitis C, but particularly for hepatitis B, with less than 10% of the estimated 296 million diagnosed and 2% treated. So if we are to move forward to achieve the targets for elimination, it needs a substantial scale up in testing and treatment and simplification of pathways. Next slide. So with the hepatitis C guidelines, which were completed last year and launched, we achieved that further simplification with the 4 iterations of the guidelines, with the simplification of treatment, expansion of the treatment to children and adolescents down to 3 years, simplified service delivery, and simplified diagnostics with point-of-care viral load and reflex NAT testing. Next slide. And this is the vision, and these simplification of the service delivery was very much supported both by the evidence as well as strong community support based on values and preferences surveys from the community for the wish for testing and treatment to be delivered in the same site, ideally on the same day, at more convenient locations. Next slide. So just as we have achieved now with the Hep C guidelines and the simplification in all aspects, so the vision was to adopt a similar approach. And this slide summarizes the table on the right, the 2015 recommendations, with right at the bottom the PMTCT 2020 update, and highlighted in red where we had seen the priorities for amendment moving forward to the new iteration of the guidelines. So with the who to treat, the expansion and the eligibility, particularly with the viral load threshold, for the first-line treatment, looking at TAF and dual therapy alongside the existing recommended tenofovir and entecavir. No change to the treatment failure, treatment discontinuation, or monitoring recommendations, but for the antiviral prophylaxis, again, considering expanding the eligibility. Next slide. And why the need to expand treatment criteria and further simplify? Well, the point I made earlier about the very low testing and treatment coverage, and that the perception that hepatitis B guidance is complex, needing the age, the Hep B DNA, and the ALT to determine eligibility, that other professional society guidelines had already lowered their Hep B DNA threshold for treatment eligibility, and recognizing that the APRI score for the diagnosis of cirrhosis, that's the group that do not need a DNA or ALT for prompt initiation of treatment, was set perhaps too high. And that we had in the original 2015 guidelines lacked data from sub-Saharan Africa. and also now addressing the recognition of the ongoing integration of hepatitis B during infection and the oncogenetic potential, and the ongoing horizontal and vertical transmission, and the opportunities presented with the ongoing cure agenda for expanded treatment eligibility. Next slide. But everybody means something slightly different by the simplification. And so I think just flagging that the simplification concept needs to apply to both the testing approach and diagnostics, the service delivery models, as well as the simplified treatment criteria to impact right across the continuum of care. Next slide. So these are the priority new directions with the planned updated Hep B guidelines for 2023. The who to treat, expanding the criteria for treatment with a potentially lower APRI score, lower Hep B DNA threshold, that should say 2000. Also looking for the first time at what might be possible for expansion of treatment, particularly for adolescents, looking at the TAF and dual therapy, expanding criteria for the use of antiviral prophylaxis, and the simplification in diagnosis and service delivery, particularly the consideration of the point of care viral load and reflex viral load testing, for the first time looking at the who and how to test for Delta virus co-infection, decentralized integration and task shifting as simplified service delivery components, and then some good practice principles for promoting adherence and retention care and applying the lessons learned from HIV. Next slide. And of course, many of you are aware of the WHO process and the guidelines based on the PICO question, that it's not just the systematic review of the evidence, but the overall holistic consideration of the balance of the benefits and harms for a particular interventional recommendation, considering resource use, cost effectiveness, the acceptability of values and preferences to healthcare workers, the community, as well as the perspectives of MOH, and feasibility issues, and that leading to recommendations. Next slide. So I think key opportunities are the low-cost tenofovir that is widely available in low and middle-income countries, the strong support now from both community and healthcare workers towards that simplification and expansion, and of course the many global initiatives towards elimination and the integrated strategies, as well as global fund support. So there are opportunities to leverage for these new guidelines. And final slide, I think. Next slide. And I think next slide. And really the key challenges are the much more limited evidence base to support recommendations in some area compared to, for example, HIV, the recognition that there is still a significant proportion of those with chronic hepatitis B infection who show minimal disease progression, and not yet fulfilling the indications for treatment. And probably the biggest barrier is the continuing lack of public sector programs for hepatitis B and adequate coverage for treatment and diagnostic costs. Thank you. So now I'm going to hand over to Dr. Billy Aristide and Dr. Sandy Mayat from the Hepatitis Program and HHS Department, who will report on the preliminary findings from a rapid survey done to really gain the perspectives of program managers on 6 of the topics in the guidelines. And this very much complements the ongoing or recently completed surveys of perspectives from the community, the patient community, and from healthcare workers. So over to Billy and Sandy. Thank you.
Yes, Philippa, thanks for introduction, and let me continue the presentation. So For this survey, the online data collection form was developed in the Google Form application in English and French language. Then the online survey form link was shared with the Viral Hepatitis Program Focus and managers from the Ministry of Health. As you can see on the slide, the survey questionnaire includes 7 sessions, where session A and B focus on the background and experience with the respondents. Then session C, D, E, F, G focus on the things that are linked to updating the hepatitis B guideline. The survey questionnaires were distributed to over 50 countries, including the high-burden countries that are usually invited to ECHO session. Within the identified timeframe, we received 32 responses from 27 countries from other regions. As you can see in the screen, 15 responses are from Afro region, 3 responses from Wipro, 2 responses from CBO, 7 responses from Euro, 4 responses from PAHO, 1 responses from CBO and EMRO. After the identified time frame, we still receive responses from countries, but due to the time limitation, we cannot include all the additional responses in this analysis, but we will use these responses for further analysis and updated the hepatitis B guideline. So to continue with the session A, there are 32 participants involved in this survey analysis. And here you can see 59% of the participants were female, and the majority, 62.5%, are from the Ministry of Health, and 18% from the hospitals, and 15% from the universities and others categories.
Excellent.
So I would like to hand over to the, here you can see, sorry, the gender and organization of the respondents. And then let me share the floor to our colleague Billy to continue the presentation.
Okay. Thank you, Sandy. Good morning, everyone. So I'll start saying that this presentation will be done in duo with Philippa. She will intervene also some of this slide. So regarding the respondent, I have to say that 88% were physician medically qualified, and most of them are public health specialists, 41%. And as you can see on the slide, the majority are direct clinical experience, around the 67%, and they spend more than 4 days a week for the management of the program. Slide. In terms of availability of national document, we noticed that 65% of the country do have national strategic plan for viral hepatitis, and 53% have national operational plan. And then 75% have guidelines for viral hepatitis. Slide, please. So more than 50% of the countries have government-funded program for viral hepatitis, and it's mostly concerned testing and diagnostic, and also for the service costs that are paid out of the pocket by patient. We notice that testing, diagnostic, and treatment are the most common. Slide, please. So regarding PMTCT, this slide is the responses from 32 respondents about the proposed expanded eligibility for the use of antiviral prophylaxis to prevent mother-to-child transmission in all HPV surface antigen positive mother when there is no access. Oh, sorry. I'm the case running quickly. So I think this slide is going to be presented by Philippa, as I told you at the beginning of my speech. Thank you. Over to you, Philippa, and I come.
Thank you. Thank you very much. And this slide relates to the responses on treatment eligibility. And I had just wanted to flag that we noticed that there was an error and a typo in the first 2 recommendations that you were asked to respond to. So I had it's a little difficult to interpret the responses for that reason, but just very briefly, recommendation A and recommendation B were very similar, but these were for treating all Hep B surface antigen with a Hep B DNA, and that's what was missing in the surveys. and it should have read greater than 2,000, regardless of ALT level or age. And that was adults, children, and adolescents. The one below, recommendation B, was exactly the same, but just focused on adults. And if we look at the responses there, remember that 1 is not agreeing. So the 1 and 2 and 3 are where there's a level of disagreement with that recommendation, and then 4 and 5 are those that are supportive. And for both the responses, there was a surprisingly high lack of support for this recommendation. I think there may have been a misinterpretation of the 1 to 5, and the converse is there, but that is why I wanted to speak to that recommendation. And then for recommendations C and D, which are on the right side, the main difference is here, it's the same recommendation, but it's looking at focusing on treating those greater than 30 years, and the one below is focusing on those greater than 20 years. And there's not a whole lot of difference between them in their responses, but this is where we were getting the higher level of support with the 4s and 5s with those responses. And then finally, at the bottom, there was the recommendation of treating all Hep B surface antigen with an abnormal ALT above the upper limit of normal where there's the absence of access to Hep B DNA. You could see that the responses are distributed sort of fairly evenly across the not agreeing, which is on the left side, and the highly agreeing. And I think just to add some of the comments, because the very rich comments that came back when we asked people, please give your reasons. So I think the general sort of responses were supportive, despite the initial suggestion on the left bar that people were not enthusiastic about expanding treatment. There wasn't strong support for treating children in the comments that came back, concerns that they wouldn't adhere well to treatment, that the use of the ALT should remain an important criteria, some wondering whether there was sufficient evidence for treating at the lower age groups, and also the recognition in sub-Saharan Africa of the early onset of HCC, and so the need to intervene sooner. Back to Billy.
Thank you, Philippa. So, talking about the PMTCT, that this slide is the responses from 32 respondents about the proposed eligibility for the use of antiviral prophylaxis to prevent mother-to-child transmission in all HBV surface antigen positive mother when there is no access for HBV DNA level. This compared to the existing recommendation where to prophylax only those HBV DNA greater than 200,000 and all HBV surface antigen positive. As you can see here on this slide, there is strong support for this recommendation across countries and region. So Philip, I will give you the floor to comment on the reason provided by the respondent to support this recommendation. Over to you, Philippa.
Thank you. Well, there was strong support for this, particularly from sub-Saharan Africa, as a way to really ensure and improve the implementation, particularly in the rural areas, given that access to Hep B DNA has been so limited. And so support generally that this would be a very reasonable approach to improve the prevention of mother-to-child transmission. The main barriers that were flagged was that antiviral prophylaxis was not available free for Hep B in many settings, that it would require availability of access to the drugs and test kits, which currently is not happening, and the need for more healthcare worker training. Thank you. Back to you, Billy.
Thank you, Philippa. So this session regarding antiviral regimen. So this series of slides relate to the use of which antiviral regimen to use for HBV treatment. The chart on the left relates to the existing WHO recommendation for the use of tenofovir and entecavir. As you can see here, there is strong support of that existing recommendation. Turning now to the two potential use recommendations, the top choice is on the additional option of using TAF, tenofovir and phenamide. And again, you see strong support for this. And the bottom chart is on the additional option of using geotherapy, meaning tenofovir and 3TC, but that is widely used in ARV services and PrEP. And here you can see some support with a little less endorsement in the bottom. So again, I will call my colleague Philippa to comment on the reason provided by the respondent.
Thank you. Well, very briefly, I think that there was a surprising number of countries who already had TAF in their recommended set of regimens, and indeed some that still have pegylated interferon. And I think some were using TAF now as first line, but in others reserved for those with kidney disease. And I think the support for the dual therapy was a little bit more mixed, and perhaps it wasn't entirely clear what the purpose of that was, which is really that this is the regimen tenofovir with 3TC or FTC is available, much more widely available in ARV services and through PrEP, and often tenofovir monotherapy is not available. Back to you, Billy.
Thank you. Slide. So this section is provided information regarding service delivery. So this slide is summarizing the responses we had from countries as to the range of health facility that AP services are provided for in the country. We can see that in the majority of countries, AP services provided in hospital-based clinic, and then in private clinic, and much fewer in primary care. So, slide. So this slide represents the 4 potential new recommendations of settings where hepatitis B care can be delivered. So when you look at the top left, the service can be delivered in the hospital-based clinic, in HIV ART services, the top right in primary care, and the bottom right integrated with common communicable disease services. As you can see on this slide, the strongest support is continuing delivering in hospital-based clinic, followed by equally at ARV clinics and primary care, and with a little uncertainty and support for provision in non-communicable disease service. So this is what we have as responses from our survey. And again, and short, I'll call Philippa to give comment on the reason provided by the respondent briefly. Okay.
Sure. Well, I think, there was broad support again across countries and regions to having Hep B services offered at all levels, primary healthcare level, hospitals, private, to really ensure that there's access to services for all, more convenient, more people being reached. So not just one approach, but multiple approaches. I think the integration with HIV ARV was supported because it felt it really optimizes human resources and infrastructure, but the concern expressed in a number of countries that stigma may be increased due to the association with HIV. And I think the integration with NCD services, there was a little bit of ambivalence here with the support that this is a good opportunity for integration to widen access to diagnosis and treatment. And if people have diabetes and hepatitis B, that's the ideal setting. And again, it can optimize human resources and infrastructure. and actually would reduce stigma in that setting. And I think just to flag some of the barriers, when we asked about barriers to delivering hepatitis B services, the familiar, the real challenge with the out-of-pocket expenses being such a common feature of hepatitis care, the lack of often national budgets for hepatitis B, lack of trained human resources, and in some countries still the high cost of medicines. Thank you.
Thank you, Philippa. And I think this is the final slide. And this relates to the HBV DNA assays, which are required to determine treatment eligibility. Two charts on the left show what is the current accessibility and availability of laboratory-based HBV DNA assays in the country. And the one below on the point of care HBV DNA assays. As you can see, this variable level of reported access and availability of DNA assays. But for the laboratory-based assays, 90% reported high level of availability of laboratory-based assays, but only 9% of point-of-care assays. When we look at the chart on the right about what will be the level of agreement, we've proposed a recommendation for the use of point-of-care assays as an alternative. Here you can see strong level of support of the use of point-of-care assays. Thank you, Philippa, to close.
Thank you. And then just the final comments on the point of care and the lab. On the lab side, with countries saying that it was often the lab assay was only available in large cities, and that many insurers, it requires special authorization, which complicates the process. I think with the point of care, the acknowledgement by a number of countries that the point of care instruments were available, but they were not currently being used for Hep B DNA testing. Or where the machines were available, but the cartridges were not, and those kits were still quite high cost, or they were based just in urban centers. And some countries were saying, we don't have the point of care yet, but it's coming, like Rwanda and Laos. Thank you.
Thank you. Over to.
Thank you. So we're now moving on to the discussion session, and I'm delighted to have with us Dr. Bibi Riwari, who's the regional advisor for hepatitis, HIV, and STIs at WHO Zero, and Dr. Casimir Mazenga-Majedi, medical officer, HIV, hepatitis, and STIs, WHO Afro, who will facilitate this session. We're going to cover just 4 topics. We'll see how we go. The treatment eligibility expansion, the expansion of PMTCT, the simplified service delivery, and the antivirals. And we are going to preface the discussion session for each of the topics with a super quick poll. But if Bibi and Casimir could just put their cameras on and introduce themselves as well. And Bibi. Well, maybe we can move to the first poll. So the next slide, please. So I'm going to read out the poll question, and you will have a minute to respond, and we will then feedback the result, and then I will hand over to Casimir, who will make the initial remarks. So this is to treat all Hep B surface antigen positive with a Hep B DNA greater than 2,000 as compared with 20,000, which is the current recommendation in those aged 20 years. So that's lower than the current 30 years, regardless of ALT level. What is your level of support. And if you can please, when you've sort of made your choice, remember 1 is the least support and 5 is the highest support. So please just ensure that you have the right direction there. And if you can provide your reason for your choice in the chat with your country, what your score was, whether you chose 2 or 5, and the reason. That would be very helpful. So 1 minute, and I think we're now just a short, probably about 10 seconds left, and then we will close the poll and look at the results, and I will read them, and then over to Casimir. So I think I'm going to click end of the poll. And the results are with support 24%, very highly support, 29% somewhat, 24% a little in the middle. And then there were, and we'd be very keen to hear from you, for those that have concern with expanding treatment. I think there's a total of 8. And then if we look at the comments in the chat, I think the points that are being raised, I'm not sure whether we're seeing the responses in the chat, so it's probably going to be difficult for me to comment. And please do, we really encourage you to, for any questions and comments, to please put in the chat. But if in response to this question, you can be putting your country, the score, and the reasons, and particularly from those who were not, were less supportive of this. Over to you, Casimir.
Thank you, Philippa, for the floor. So we can see here some more some suggestion. The most of the country are supporting this eligibility expansion, and I don't have here some more questions in the chat, but let me see with some countries what they are thinking about this question. I saw Justin from Rwanda. You can take the floor to make your comment. Justin from Rwanda. Are you online, Justin?
And if we can unmute them, thank you.
Maybe, okay. After this, I have also a point of view from Ivana from Serbia. Can you go ahead, please?
Good morning, everybody. It's a pleasure being with you. Can you hear me?
Yes, yes.
Okay, so we are strictly stick to EASL guidelines when we treat patients with HBV infection. As a matter of fact, we have a very good coverage with 3 vaccine dosages in newborns, over 95%. So we rarely see very young people, and even those above 20 years, with chronic hepatitis B nowadays. And if we decide to treatment, they have to fulfill criteria which are defined by European Association for the Study of the Liver guidelines. So our national guidelines are basically the same as EASL guidelines.
Thank you, Ivana, for your.
If those one more remark, please. If those patients have hepatitis B antigen positive or negative hepatitis, we are going to treat them. But if they just fulfill criteria for antigen positive or negative chronic infection, we are not going to introduce antivirals. Thank you very much.
Thank you, Ivana, for your points. I go now to Justine, because I can see that she was talking, but we did not be able to understand what she was saying. So please, Justine, over to you. Maybe she can have some problem with the mic. So
can you hear me now?
Yes, Justine.
Yes. Oh, it was the problem was the microphone. Thank you. Yeah.
Okay.
I just want to suggest, as we want to systematically treat every pregnant woman once we do not have HBV DNA platforms. However, I think we have to pay attention, because sometimes on the first test, we need to confirm to know whether there will be a virus clearance or not. And this is why I was suggested that at least before we treat, the pregnant women should beneficiate like 2 tests. And once those 2 tests are positive, at least we can treat, because we are at that time sure that she has a chronic HBV infection. Otherwise, if we treat at the first test, I don't think it could be a good alternative. Thank you.
Justin, thank you for your points. Can you just explain what can be the duration between the two tests?
Actually, the duration is 6 months. According to previous WHO recommendation to confirm the chronicity HBV, it was recommended to perform the first test, and then confirm after 6 months. If the test is again HBV surface antigen is again positive, this time we can confirm a chronic infection. Thank you.
Okay, because sometimes the problem is that the pregnancy is just for 9 months, and the pregnant woman came at the second quarter, so sometimes it will be difficult to have both the two tests during the same pregnancy. But let me give the floor for the first and the second question to Philippa for some light about the two first points. And I encourage also other colleagues to put on the chat the point of view and some questions for us to be to take the benefits from this important session. Philippa?
Thank you. And just to respond to Justine's comments, and thank you for all these comments, that the requirement is really just for a single Hep B surface antigen test. I think at one stage the definition of chronic hepatitis B infection was the 2 Hep B surface antigen tests 6 months apart. But I think the reality is in adults that single Hep B surface antigen is generally what is used, and certainly in the context of pregnancy, that would be the case, and they would be eligible for antiviral prophylaxis with the current recommendations with viral load 200,000, but we're looking at the prophylax, not treat all, but prophylax all Hep B surface antigen if you cannot get access to the Hep B DNA. And I really just, and I think we just have a few more minutes for this one before we move on to the PMTCT, which is what we're going to discuss next. And it was really just to ask the group that if the eligibility is lowered to 2,000, which is probably only going to account for about a 15% increase in absolute numbers in countries, are there any concerns and considerations for those that were voted that weren't supportive of this recommendation Can you perhaps elaborate? And yes, I think Nigeria, Casimir, maybe to ask Nigeria to comment.
Yes. Nigeria, go on, please. Go ahead, please.
Okay. Thank you very much for giving me the opportunity to share Nigerian experience. My comments with regard to this eligibility criteria has to do with the fact that we have a technical working group, and despite the availability of WHO guidelines, we still have our group where we look at data, look at evidences from different treatment centers, and that help in forming some of our recommendations. So based on what I put on the chart, I will advise that every recommendation should be evidence-based, not subjective. And also in Nigeria, for now, everything is out of pocket expenses. So it will be insignificant to us at this moment, because what is the point of lowering down the eligibility criteria and people are not having access to this treatment? So that is just our take from Nigerian angle. Thank you very much.
Okay, thank you, Nigeria. Philippa, please let another comment from Arjan, so we can summarize our point. Arjan, please.
Yes, can you hear me?
Yes.
Well, I'm a clinician, so I treated a lot of patients with HBV, but I voted for 1 or 2 points for the question that when you ask about the lowering the threshold for HBV DNA. The reason is that you have to balance. First, there is no European guidelines, so I'm not aware of any evidence-based. Maybe I'm wrong, but my concern as a clinician is that you want to treat to prevent like chronic hepatitis, but to explain this to patients, it's not easy, because I said in my comment that most of them, they get exhausted because they ask when I'm gonna stop this, this treatment, because you cannot tell them it's gonna be 3 years, 5 years, 10 years, or for life. So it's not a definitive therapy. There is no defined clinical endpoint for this therapy. And the other point is the side effects. So you mentioned TAF, but TAF is not available as generic. So it's difficult to have TAF in context when the constraint, the budgets are limited. So these are the issues that I had in my mind when I voted for 1 or 2 for that issue. Thank you.
Thank you, Arjan and Jamil, for your question. So let me leave the floor to Philippa for to summarize our point of view.
Thank you very much, and I really appreciate these comments and continue to have them coming in. But I do think we need to move on to the next one. But I think this discussion has demonstrated that there is not a unanimous support for just expanding the criteria, the importance of having evidence, the consideration of the fact that patients are paying out of pocket themselves, the need, if they are starting treatment, to have that support and motivation to adhere. And I think the earlier comment about, at least in Europe, where there's been high vaccination, that you rarely are seeing young people with hepatitis B. So on to the next poll number 2. This will be a quick one because we've kind of touched on this issue before, which is really the expanding the eligibility potentially to include all Hep B surface antigen positive mothers where there is no access to Hep B DNA as an adjunct, obviously, to the vaccination. So please start your vote now. Again, if I can just ask you to put your responses in the chat, the rationale with your country, your score, and your reason. So just about another 15 seconds, and then we will close the poll, and I think it will then be over to Bibi to discuss and facilitate the discussion. So I think we still have people voting. And remember, 5 is the highly supportive, 1 is the least supportive. So I'm going to close the poll in 5, 4, 3, 2, 1. So what we have is 44% highly supportive, 26% somewhat supportive, 21% a little in the middle, but overall adding the 3, 4, and 5 are very there's some background noise. Please do mute yourself. So only, I think, 3 that were not supportive of this. So let us now turn this over to Bibi, and please keep your comments coming in the chat.
Thank you, Philippa, and good morning, good afternoon, everyone. I will, Philippa, rather like to combine the 5 and 4 and see that 70% of people are supportive and fully supportive, if I look at that way, because when the survey that we have got from 27 countries, most of them have supported this for various reasons, and the reasons given are very kind of genuine reasons, like accessibility to HPV DNA is issue in most countries, particularly low middle income countries. It is a complex procedure, expensive, and particularly when we talk of decentralization of service delivery, this could be a barrier, particularly for pregnant women. Also, there is expenses to patient, out-of-pocket expenses on transport, missing their work when getting for DNA. Some of the other reasons that have been cited in the survey, and I will wait for the chat also, is that when we are talking of elimination of hepatitis B mother-to-child transmission, we really need to get the maximum kind of coverage and protection to prevent that transmission and elimination. So this algorithm has also been suggested that this also prevents loss to follow-up, though some of the countries have not agreed to it because it is not in the WHO guideline, but now we are talking of modification of these guidelines. So there have been some very good responses in this regard. And I would like to now invite, also there is a comment that we do not have enough capacity, so it will be excessively protect the missing opportunities. Fully agree to that comment from Ravanda. I have Facha here from Indonesia. I'm specifically asking her for comments because we have seen that the cascade of care for pregnant women in Indonesia were exceptionally good, and she presented this at World Hepatitis Summit. So I would like to request Facha for her comments on this. Over.
Okay, thank you, Dr. Riwari, for this opportunity. So according to our country, Indonesia, we are now conducting the prevention for pregnant women of hepatitis B. So because of our limitation, because of our limitation in facility, pregnant women who get positive from tests, it is diagnosed with HBe antigen and test for the ALT, the function of the HEPA. If the result is normal, so they can conduct the prevention treatment in primary health center. But if they got the problem with the ALT, the pregnant woman should refer to the hospital, to the second referral services. This is to prevent the loss of follow-up for pregnant women who being tested positive because of lack of the DNA HBV test in survey in primary health center. Thank you, Dr.
Thank you,
Ewari.
Facha. I think I am getting two very good questions which have come in the chat. Basically, what are the recommendations to assess and manage flares after the stopping treatment? Because we'll be stopping treatment in pregnant women after a period of maybe around 3 months total. And what to do with mothers after delivery if they are not meeting the criteria for treatment. My perspective on this is linked to the earlier discussion also. And I would request Philippa for her comments on this before I move to another one from Abdullah. Over to you, Philippa.
Yes, thank you. The specific point you wanted me to respond to, Bibi?
It is basically what to do when we stop the treatment if she's not meeting the criteria for treatment. What about flares and all those issues?
Yes, and I think something that came up in the survey result was the recognition of the lack of a well-defined care pathway for those with hepatitis B. We're starting to now see traction on the testing for HIV with hepatitis B as well, and syphilis. But while the care pathway for ARVs and the HIV positive are well-defined, there is a lot of confusion about where the pregnant woman with hepatitis B goes next, and they need to see a hepatologist. So I think, and this will of course apply in the context of flares, that clearly there needs to be a clear care pathway of initiation of tenofovir, evaluation of whether the pregnant woman has a need for long-term tenofovir for her own health, and then the issue, if it is just short-term prophylaxis, the access to some ongoing supervision. Having said that, I think the data that has been shared to date, and I think there needs to be better data, is that the incidence of flares, and certainly significant flares, is very low. But I think this needs to be looked at systematically with a longitudinal cohort study.
Thank you, Philippa. I'll move to the next question, which is from Abdullah. And it's a very good question. If we add e-antigen to algorithm for pregnant ladies, will guard against those who are with undetectable viral load or less than 2000, as it is said. So he says it is less costly than PCR. So Abdullah, I would just like to know from you, when you say it is less costly, but availability again becomes the issue, because we are trying to move away from the barriers, particularly the availability, the cost for DNA, which is less for e-antigen, but still availability. So I would like to have your views on this. Over to you, Abdullah.
Thank you, Bibi. I believe that the antigen is quite available, but still we are facing challenges because service in Sudan. I am from Sudan. The service in Sudan is, as much of the countries, is centrally, not decentralized yet. But we were considering this option because of I used to ask the companies who are producing the RDT if they have like rapid testing for e-antigen, if they are thinking of producing such rapid test, it will be of a very good benefit. Another thing is the gene expert machines that I believe it is available also in countries that are supported by the Global Fund for TB and HIV. Also, we sought to integrate the testing of viral hepatitis, viral load with those gene expert machine, because it has the capacity to test for the viral load for HIV, as you know, detecting TB, and also viral load for hepatitis. So this is going to a breaking through if we could add this integration of viral load hepatitis. We have in the country like 95 machines all over the country, all over 18 states. So over to you.
So thank you, Sarah. I think given some concerns and non-availability or limited availability of both DNA and E antigen, I think the response is the reason for us such a strong 70% response is to provide antiviral to all pregnant women, irrespective of DNA, for the reason of accessibility and increasing the coverage and preventing the transmission. So I think the time is a limited factor. So I hand over back to Philippa for comment and move it to the next poll. Thank you.
Thank you very much. I think that's a very great summary. Thank you. So the last part of the poll, we're going to skip poll question 3, and I'd like to go to the service delivery, which is 4, 5, and 6. So Ramina, if we can go to those very quick poll questions and to have some feedback. So we're going to be asking you 3 questions very quickly. I'll only give 30 seconds for each of these. And the question is about providing Hep B services at primary care as one of the important ways to expand access, but clearly with some constraints. So again, the 1 being the less support, 5 being high support. So I will close the poll in 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Ending the poll, and please give your reasons in the chat along similar lines, but we have 50%, 28%, so that's 78, almost 80% supporting primary care. But as we saw in the original presentation, currently only 20% around of care, hepatitis B care, is being delivered in primary care. And the next poll, if we can, Ramina, go to that, poll number 5. And this is on the integrating hepatitis B services where appropriate, using the HIV clinic infrastructure and staff to deliver hepatitis B care that's been adopted in some settings. So again, your responses, and 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. End the poll. And so here, very similar, with almost 80% supporting making the use of HIV services, bearing in mind the comments that were raised in the survey about the need to rename potentially the HIV clinic so that it's not the association with just this one disease, and that may create more stigma. And I'm moving now to the final poll question, again related to service delivery. And this is about providing hepatitis B services integrated with NCD clinic services where they exist. And this is perhaps a little less commonplace. So please make your votes. So again, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. End of the poll. And less support, and that is consistent with what we saw in the overall survey, with 32% strongly supportive, 26%. So overall, around sort of 60% almost, but quite a few who had reservations, amounting to about 25%. So clearly some considerations there. I think here in the survey, it was in part because there weren't that many NCD services that had been that were available. So it was a lack of opportunity to be able to integrate. So I'd now like to open it up. Was it Casimir, back with you again, to facilitate just the last? I think we really just have 5 minutes, and then we can hand over to Fumi for the closing remarks. Over to you, Casimir.
Thank you, Philippa, for the floor. So we have many supporting responses for the service delivery in HIV, primary health care, and also NCD services. So now we can go to the comments to see what are some comments from the countries. Let me start with Jamiu. Jamiu, you have the floor to give your share your point of view.
Okay, thank you very much, Dr. Kasmil. I strongly support the 3 options, especially that the one that has to do with the providing hepatitis at primary healthcare level. We are talking about universal health coverage, and also talking about the issue of patient-centered approach. I think the way to go is leveraging all opportunities, all resources at the primary healthcare level. And in our own guideline, we've already structured that in our guideline. But what we've been able to do in Nigeria is to kind of have a minimum package at all levels. So we are using our primary healthcare as one of the key opportunity to actually leverage on existing services, as well as achieving universal health coverage. Unfortunately, it is still out of pocket, but we are hoping that with more funding and so on, we'll be able to achieve that. But that is what we've been able to do at the moment in the country. And also, we also support integration, and I'm happy to see that. Currently, we've applied for Global Fund support. So one of the key areas we're looking at is HIV hepatitis integration, and we've already submitted that in the proposal. So we're hoping that's another good opportunity to get people into care. And also on NCD, we're also working on something on NCD to integrate that. So I think integration is the way to go. It will reduce a lot of duplication, and it will allow the opportunity to harmonize human resources and other essential health-related resources. Thank you very much.
Those are the great points, my brother. Thank you for your comments. Other comments, Dr. Mbela from Cameroon?
And Rwanda as well had the hand up.
Okay. I will come back to Rwanda. Dr. Mbela from Cameroon? Okay. So, Rwanda, you have the floor.
All presenters and comments. I don't know if you are hearing me.
Yes, yes.
Yeah.
Okay. Thank you. I am happy that now we are discussing these practical things, especially on hepatitis. So mine is back to the integration. Yeah, really, this is the way to go. But
yes.
When I saw the first question on integrating within HIV services, I was like, the middle. Actually, I selected number 3. Why? Because I say as country we need to consider what the level of stigmatization, because when you integrate hepatitis, viral hepatitis within HIV services, it's good when it's come to targeting those already co-infected, but just thinking of those not co-infected with the label of HIV services, how would we go for that? That's my concern, and any experience you can share from others. Thank you.
Okay, thank you. I agree with the integration for HBV services in HIV services, but the concern is about the stigma. I don't know if someone can share the experience about this problem of stigma. Is this the issue we are facing on? So maybe some other countries can share the experience. so I don't see. Yes, Philippa.
I was just going to say, I think we probably need to now close out the discussion because we're reaching the 1/4 timeline.
Philippa, Philippa, just one comment, because it is very important when we talk of service delivery that lessons that we learned in decentralization from HIV program over 20 years, we should implement in the hepatitis program urgently rather than wait for again similar experiences, because being a lifelong treatment, retention is important, and cascade of care approach that we have seen in HIV should help in this. And lastly, because time is a constraint, community involvement like we have seen in hepatitis C, we have not seen that in B. So these are some of the areas where we need to really focus on. Thank you very much.
Thank you so much.
Thank you.
And
Thank
for
you,
that,
Philippa.
and thank you both so much. And for that last comment on really how much we have to learn from HIV about the simplification service delivery. Just to let you know that we do have a systematic review ongoing at the moment. We didn't think there were going to be enough studies, but we've managed to find enough to do a quantitative as well as a qualitative synthesis. But the models are still there's quite an array of models, and we certainly don't have the level of evidence as was the case for HIV or even hepatitis C. Before handing over to Fumi, I just wanted to make one final request and thank you so much to all those Ministries of Health that rapidly filled out the survey for very appreciative, extremely valuable information. For those countries that have not yet completed it, we would like to have the benefit of your input because this is going to be presented at the guidelines meeting alongside the other surveys. This really counts and really makes a difference to the discussion. So we will send out the survey again to give you the opportunity over the next week to complete if you haven't done so. But thank you so much for all the input and the great discussion. Over to Fumi.
Thank you very much, Philippa. And this has been a most meaningful and stimulating meeting with nearly 90 participants joining us. And what is clear is without simplifying the guidelines, without simplifying service delivery, we really cannot reach the elimination target for 2030. The three themes that we see from this meeting is related to prophylaxis among pregnant women to prevent mother-to-child transmission. That seems to have been unanimously endorsed and agreed. The treatment for more adult patients because they have a huge risk of liver cancer, and the importance of integration with other service delivery areas. So ultimately, we look forward to the guideline meeting, which will hold in early May. And we hope that the guidelines will alter the trajectory of the hepatitis B response towards elimination and prevention of cancer. And the feedback from this webinar will provide important considerations because we have heard the voice of the program managers and the policymakers from countries. We thank you sincerely for your participation in making this meeting so successful, and we value your experience and shared feedback. We particularly thank the WHO and ECHO team, and we appreciate Dr. Philippa, Bibi, Casimir, Billy, Sandy, who have contributed to make this meeting very exciting. Our next meeting next month will be on hepatitis data, how to generate data, how to use data for managing hepatitis programs. So we thank you all very much and request that before you leave, please answer the feedback survey through the link that has been shared in the chat. We would leave the platform open for a few minutes so that you can complete that feedback in the chat. And on behalf of the entire GHP team, again, we say a huge thank you, and we look forward to seeing you next month. Thank you very much for joining us this week.
Thanks, everyone.
Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye. Please fill the chat. We are waiting for all the responses in the chat. The chat will remain open for your responses. Thank you. Thank you.
Hi, for me, it's Billy.
Hi, Billy. Thank you so much for being part of this seminar, this webinar. It was really excellent. Thank you for your participation and for sharing the feedback from the polls.
Thank you,
Philippa, for the coaching.
Up to midnight, up to midnight.
Up to midnight.
Yeah. And you know, it's great to see people from different regions, from the Euro region, from Afro, from Wipro, from CRO. We do know that hepatitis B has a different epidemiology, and challenges from different regions may be different. The platform remains open for the polls, for the survey, so please fill the survey. Thank you.
Okay, bye.
Bye.
Yeah, you're enjoying.
The survey is not working, I'm told.
Yes,
Romina,
it's not working.
the survey is not working.
Kindly give us a minute.
Not loading at all.
Survey is not working. Yeah.
Okay, we're going to close the portal. I think the surveys will be sent to everyone by email. Romina?
Yes, for me, that is correct.
Thank you. Okay.
Okay.
Fine.
Are we able to send the full survey link? Because Sandy can put that in the chat.
Okay.
Sandy, are you there?
Yes, Philippa. We will send a follow-up email to all the participants, and at the time, we will include the link to the survey and also the link to the feedback form.
Great, great. That's
Yes.
right. We've got everybody.
And also there will be, yes. And also on that follow-up email from ECHO, they will get the link where they can access the recording of this session also. Yes.
Okay. So more comments that the link is not working, cannot be opened. I think that will be addressed. And on that note, I'm going to say a huge thank you to everyone. ECHO, can you just close the session? Thank you very much. And over to ECHO to close the session.